serving as chairman of the Medical Advisory Board. Dr. Roer is an active advocate for kidney patients. His 2003 testimony for the medical necessity of home dialysis helped secure continued Medicare coverage for home dialysis patients. The NAF honored him with the Patient Advocacy Award in 2005 and the Gift of Life Community Service Award in 2008. Dr. Roer is also a member of the DaVita Physician Council and is the Group Medical Director for Team Avanti and Titan. Take it away, Dr. Roer.
Well, thank you, Tracy. It's great to be able to spend the next hour or so with everyone. I hope it is as beautiful where you are as it is here in New England. It is sunny and almost 70 degrees. So today I'd like to talk about transitions of home therapies. My assignment was specifically to review transition of a peritoneal dialysis patient to home hemodialysis. We'll talk about other transitions as well as we move through the presentation. So objectives for the talk are to view home modalities options through the transitions of renal replacement therapy and to strategize and what are the strategies to maximize home dialysis technique survival to be able to maintain patients on their modality of choice. So I'll start with a short case of Mr. H, who's a 53-year-old gentleman, end-stage kidney disease secondary to diabetic nephropathy. He works full-time and is on the deceased donor transplant list. He's done well on CCPD until recently. AT over V has fallen to 1.2, and his daily ultrafiltration to only 600 cc's per day. He is icodextrin and hypertonics dialysate to maintain ultrafiltration adequacy, and unfortunately has had 2 episodes of methicillin-resistant staph aureus peritonitis in the last 16 months. And we'll discuss what his treatment options are at this point in his care. On the slide, there is a listing of home modality transitions, the number of ways patients can come to and change home modalities. They can start on a home modality, the home first strategy. Patients can come from the hospital to home, and I think on next week's call, urge start peritoneal dialysis will be reviewed in some detail. Patients can transfer from in-center to home, after failed transplant to home, from home to transplant, PD to HH, and HHD to PD. And there are a number of issues that I will touch upon, some of these that help to maintain modality of choice for the home patients. And especially when patients go to the hospital, they are vulnerable to hospital-acquired infections, and being sure that we have good processes at our local hospitals to try to prevent that. And so when patients go to the emergency department is another vulnerable tradition of care for our patients. And there are strategies, as you know, that we have to try to prevent or stall patients from going into the emergency room with oral antibiotics for suspected peritonitis. And then the number of complications, both the infectious and non-infectious complications, and I'll run some of these a bit, and I know earlier in the series Dr. Bargman spoke to these in some detail. The next slide shows the continuum or life plan. I actually adopted this slide from Dr. Best from Baxter, and I think this puts into perspective the continuum of patients as they develop chronic kidney disease and transitions to end-stage kidney disease, and then the options that patients have. And as they continue on from their initial modality, how we maintain them on that modality or change to another option. And And then importantly, transition to end-of-life care as the patient chooses that new mode of therapy. Just in background, as you know, the United States lags in home dialysis therapies for dialysis for the prevalent patient in the United States is only about 7% of the entire population. And you can see on this slide that other countries have significantly greater penetration as compared to Hong Kong or New Zealand or Australia to the United States, where the United States penetration is only about 7%. So really there are countries that have strategies in place to initiate, maintain patients on home therapies, and we'll talk a bit about that. So it's important early in the life plan to begin discussions with the patient, with the family, with primary care physicians about the transition to renal replacement therapy. And it's in fact very, very important. The next slide highlights that as patients become more knowledgeable about modality choices, they often choose dialysis. They often choose home therapies. So here are the percentage of patients who choose a particular modality, and in blue is peritoneal dialysis, and in red hemodialysis. Although chose that modality, they actually start on peritoneal dialysis a little less frequently, but surely much greater than the U.S. incidence was around that 7% mark. Here it's about 30% actually start on dialysis, and about 45% chose dialysis, and we're not able to make that transition for a number of reasons. And yet another study that emphasizes the importance of pre-dialysis educational programs, in this that was done in 2005, there were 235 patients, 185 of whom went through dialysis educational program. And with that, you can see that about 30% of patients ended on peritoneal dialysis and about 9% on hemodialysis. So this strategy of pre-dialytic education improves the educational knowledge base of the patient and can make more informed decisions. And as you can see, they often choose peritoneal dialysis. Yet another study that emphasizes this, also more recent study, published in the American Journal of Kidney Disease last year, and I just highlighted on in here the percent of patients that started on peritoneal dialysis after undergoing a educational program called TOPS, which is Treatment Options Program. And if you look at the percent of patients who started on peritoneal dialysis in the entire population was 5.9%, but in those who underwent the educational program, 24.5% start on peritoneal dialysis, once again emphasizing the importance of education and patient choice. It's very important in the PD first strategy to understand that even in patients who start on peritoneal dialysis and then end up transferring to hemodialysis live longer than those patients who started on hemodialysis. And in this study, and on the slide, this is survival over time in months. Solid black line that patients who started and continued on hemodialysis dialysis compared to those individuals who started on peritoneal dialysis and then switched to hemodialysis. Over a period of time, patients who initially started on peritoneal dialysis but yet switched to hemodialysis had a 40% greater survival rate than those who started initially on hemodialysis. So even if it is thought to be only for a short period of time, a few months or a year, the initiation of peritoneal dialysis first results in better outcomes. In the patient presented, his ultimate goal was to be transplanted. So this patient was now on peritoneal dialysis, unfortunately with technique there, but he still wants to get to transplant. And it's important to understand the modality at which the patient is on prior to transplant. In this study that was published this year, we looked at pre-transplant dialysis modality and post-transplant outcomes for this entire population. And in the solid black line here is peritoneal dialysis patients, and in the lighter gray line are hemodialysis patients. And this is cumulative survival in the follow-up years after transplant. I think in highly statistically significant way, the patients who were transplanted from peritoneal dialysis have significantly greater survival than those patients who were transplanted after hemodialysis. And similarly, if one looks at cardiovascular survival over time, peritoneal dialysis patients in the top solid black line had greater cardiovascular survival than in individuals who were transplanted after being on hemodialysis. So early in the transitions of care to renal replacement therapy, when transplant is part of the life plan strategy, transitioning from peritoneal dialysis to transplant offers a survival advantage. And, similarly, in that same study, they looked at multivariate analysis, looking at how well patients would do after transplant. And for almost all of the variables, there was a trend towards improved outcomes in patients that were on peritoneal dialysis prior to transplant. So this is the line of identity, the red line. Everything to the to the left of the red line is a lower risk for PD and higher risk for hemodialysis. So once the patients chose peritoneal dialysis, it's important to try to maintain both technical and psychological success. And in this patient, unfortunately, he is now developing technical failure. I'd like to discuss a few techniques that could increase the likelihood of technique survival for patients on peritoneal dialysis. And we'll touch briefly on some issues around infection, catheter function, preservation of residual renal function, peritoneal membrane preservation, and maintaining adequacy and volume control. Over the last several decades, there's been a significant improvement in infection rates due to new innovations for peritoneal dialysis and new protocols. And on the slide, where it looks at peritonitis rates per patient year over dates of time, and key events that happened, such as YSET was introduced, that helped to decrease peritonitis rates, reduction of Staph aureus prophylaxis, the spike assist device, and in each strategy there was a progressive decline in peritonitis rates. And you can see early in the 80s, peritonitis rates were almost 1 per year. And as time has gone on, that has significantly been reduced to about 0.2 to 0.3 episodes per patient year. So tremendous improvement in both technology and protocol adherence. In of prophylaxis of exit site infection is really critical in maintaining a functioning catheter and preventing peritonitis and loss of the peritoneal membrane. And this was the use of gentamicin cream prophylactically to reduce both gram-negative and gram-positive infections in peritoneal dialysis patients. And this slide represents the improvement in exit site infections per patient year based on the type of exit site care that was given, whether it was Mupirocin or Gentamicin. And you can see in both incident and prevalent patients that the Gentamicin protocol led to significant reduction in negative and also gram-positive exit site infections. So referring to protocol to prevent exit site infection is an important strategy to technique survival. Excuse me. And in the same study, the gentamicin group compared to the Mupirocin group showed a significant proportion of patients did better with gentamicin than when Mupirocin in preventing time to first exit site infection. So again, this is time to first exit site infection. The gentamicin group did significantly better. Sorry. So similarly, when dilute bleach was introduced into protocols, Alkavist, in addition to either Mupirocin in this study or gentamicin in others, yet a significant reduction in exit site infections and time to infection. So this is annualized rate. This is the Mupirocin only treated group. This is the Mupirocin and Alkavist group, resulting yet another reduction in incidence of exit site infections and prolonged time to infection. And similarly, that led to a reduction in peritonitis rates, again, annualized rates for the Mupirocin group and the combined therapy group. This is to reduce peritonitis and exit site infection. Again, the combined therapy had significant improvement in infection rates. This is just more of the same, presented a bit differently, and this is catheter removal because of infection. This study was actually done in children, comparing Mupirocin and Alkavist Lacson. And you can see individuals who are on the combined therapy, the solid dark line, had survival of their catheters significantly more so than those with just single Mupirocin therapy. So not only does this strategy reduce exit site infection, it reduces peritonitis, and it also reduces the risk of catheter loss. And in this study, the catheter removal because of infection decreased from 1 in 38.9 catheter months in the Mupirocin treated group to 1 in 94.2 catheter months in the Mupirocin Alkavist like therapy group. Highly significant improvement in those infections. Also importantly, and I know Dr. Bargeman spoke to this earlier in the series, the importance of maintaining residual renal function and urine volume to improve outcomes. And this is from one of her studies in 2001. And I'll highlight that maintaining a urine volume of greater than 250 cc's per day or greater resulted in a 36% decrease in the relative risk of death. And it's just highlighted on this table from her paper, showed a significant reduction in relative risk to death, one being the benchmark, and this was 36% lower risk of death by maintaining urine volumes. And also by maintaining GFR of 5 liters per week resulted in a 12% reduction in relative risk of death. So techniques to maintain urine volume and maintain intrinsic renal function or residual renal function is an important aspect of outcomes for the patients. What are some things that can be done to help this? And in terms of maintaining urine volume, this is a study that compared ramipril, an ACE inhibitor, to those patients who did not receive ramipril. And this was looking at the progression to complete anuria. So an important predictor of technique failure and outcomes. So this was the probability of anuria over months. The top group is the control group, and the black line is the ramipril group. Significantly less patients developed anuria when treated with an ACE inhibitor, ramipril. Certainly, can this medication be used for blood pressure control? But can be used for decreasing the progressive decline in renal function even after starting dialysis. And this shows the mean residual renal function and the decline in renal function over a 12-month period of time. And in those patients treated with ramipril compared to control groups, this is the ramipril group, they had less loss of residual renal function when treated with ramipril. The next slide highlights the importance of the continued use of diuretic therapy in patients who are on peritoneal dialysis. So diuretic help to preserve residual renal function. And the graph looks at urine volumes in milliliters per day, 24 hours over time. In those patients who high-dose diuretics were used, and these were dosages of furosemide of 250 milligrams a day, and metolazone was added if the furosemide did not achieve a urine volume of 500 cc's or greater per day, and urine volume was maintained over that 12-month period of time in the diuretic group, significantly more so than in the control group who did not receive high-dose diuretic therapy. Important to use diuretics. Often high dosages need to be used in order to achieve this outcome. So again, an important predictor of technique failure and also an important predictor of outcomes for our patients on peritoneal dialysis. So important to try to maintain clearance. And another advantage of using ACE inhibitors or angiotensin receptor blockers is to maintain solute clearance. So this is the control group in the diamonds, and in the squares, the ARB ACE treated group. And you can get over time, and this is in years, that there was progressive loss of filtration or solute clearance in both groups, but to a much greater degree in the group that was not treated with ACE inhibitors. In the group with ACE inhibitors, loss of solute clearance was significantly less, and shown similarly here. And this was what percent of patients in the groups were on ACE inhibitors or ARBs consistently. And clearly, if the vast majority, 75%, were maintained on ACE inhibitors, they had the least decline in solute clearances. Setting back to our patient who now was maintained on peritoneal dialysis, he is having both clearance failure and ultrafiltration failure. He wants to remain home. He's independent. He works full-time. This will continue to support his lifestyle until he's able to transition to a deceased donor transplant. So what we need to do for this patient to help him through his transition, well, early on as we recognize the failure in peritoneal dialysis, is to preserve his arm and to obtain an AV fistula as soon as possible, avoiding the need for a central venous catheter and insert hemodialysis backup. Important is to begin early options therapy and to begin education both of his family and caregivers of the technique of home hemodialysis and the advantages and disadvantages of this therapy. This way we can electively transition to home hemo and eventually transition to transplant. There are a number of psychosocial issues that will undoubtedly be serviced during this important transition time. And I think for our patient, he has a lot of intrinsic motivation, which will lead to much better outcome. He will be able to maintain control. He'll have self urgency and a good social support mechanism as we start the process early in his transition period. And our anticipated complications of hemodialysis, and trying to anticipate these and have strategies to avoid them will help him maintain home therapy as he transitions to transplant. I do want to touch on one or two issues that have become more important and potentially preventable problems with our patients who are at home using buttonhole technique for AV fistula cannulation. So Staph aureus, Bacteremia, and buttonholes is a significant issue. In this study that was published about 2 years ago, looked at infection rates. So these are events per 1,000 fistula days. In pre-intervention era, showed a rate of about 0.23 infections per 1,000 fistula days. With intervention with placement of Mupirocin on the site at the time of needle withdrawal, reduced that risk by tenfold. So simply placing Mupirocin at the buttonhole site when the needles are removed led to a highly significant reduction in buttonhole infection rates and bacteremia. Similarly, back to the life plan, I think for all of our patients, this is a good schematic and sheet to think about as patients move along this continuum and as they transition to different modalities of renal replacement care. And with that, I thank you for your time and love some questions and thoughts.
Thank you so much, Dr. Roer, for your presentation. Sarah, let me go ahead and start our Q&A.
At this time, I would like to remind everyone, in order to ask a question, please press star, then the number 1 on your telephone keypad, and we'll pause for just a moment to compile the Q&A roster. And again, that's star, then the number 1 on your telephone keypad. Next question comes from the line of Rachel Santomoro. Your line is open.
Question, it was answered.
Again, if you would like to ask a question, please press star, then the number 1 on your telephone keypad.
So, Dr. Roer, while she is completing those, I had a question for you about the buttonhole. Do you have your patients use antibiotic ointment, and when do you have them apply that?
Yes, we do have a protocol in our unit. I have a home hemo unit with about 20 patients in it now, and all of them who have buttonholes use either triple antibiotic ointment or Mupirocin. On the buttonhole site at the time the needles are removed. And we have luckily been and very fortunate to have a very, very low buttonhole infection or bacteremia rate.
That does go along with the DaVita policy as well, so thank you very much.
Mm-hmm.
And do you have any additional questions?
There are no questions in queue.
Great. So again, to everyone, you do have the option to ask questions in 2 ways. You can ask them in person, or you can type them into your chat box. I will read our first question that was typed in. Patient is sensitive to Alkavus. What do you suggest they use?
There are a number of alternatives in the policy and procedure manual. Chlorhexidine is an option, and Trey could help me with what other options there are in the policy and procedure for DaVita.
I think chlorhexidine is the main one, and we do obviously recommend Alkavus as much as possible.
And Trey, have you seen any other after patients who are super sensitive to Alkavus?
Chlorhexidine.
That's just it? Okay. Thank you. I have another question for you, and this is more related to your general presentation. There is a program manager out of Tuscaloosa that wants to know if it is okay if they see a copy of your deck for use in patient education.
Absolutely. The current deck?
Yes.
Yep. I'll be happy to share that.
Excellent.
Send me a request on email.
Okay. Okay. Another question for you. This is again regarding patients who might be sensitive to Alkavus. Can they use soap and water? Is that a suggested use?
Yeah, so soap and water is another option. I think using an antiseptic is probably a bit better, but if there aren't other options, a bactericidal soap and water is an acceptable alternative.
Fair. Do we have any questions in queue?
You have a question from Thea German. Your line is open.
My question relates to the PD advantage that you showed in your earlier slides with hemodialysis. And my question is, did that take into account also our more frequent home hemodialysis therapies or the longer nocturnal, or was it only the traditional in-center?
Well, thank that's a great question. The studies looked specifically at in-center 3-time-a-week hemodialysis. It did not look to compare either nocturnal in-center or home therapies or more frequent in-center dialysis or home frequent dialysis. So those were really just comparisons between the two traditional modes of peritoneal dialysis and in-center hemodialysis. I suspect, and I don't know specifically, but I can surely get you that information, that outcomes would probably even be better from the more frequent dialysis patients.
And there are no further questions.
I'll go ahead and read a question from our chat section. This particular nurse wants to know, what would you suggest we tell a PD patient that is on a transplant list, who is also diabetic, but they're compliant with watching their weight?
So that's a common and difficult situation. As you know, patients often will gain some weight on peritoneal dialysis, and many transplant centers have a BMI above which they'll exclude transplantation. So I think it's very, very important to try to maintain ideal body weight, surely working with the dietitian, appropriate exercise, limiting hypertonic dialysate to reduce the caloric from the dextrosolution. The use of icodextran, when appropriate, to decrease the need for hypertonic dialysate. I think are some general techniques that we can use to try to limit or prevent weight gain, but it's a challenge.
Perfect. Thank you. Any more questions?
There are no questions in queue, but again, if you would like to ask a question, please press star, then the number 1 on your telephone keypad.
And while to compile those, I'll read another question from the chat box here. A person wants to know, to use Alcavis to clean the exit site, but is using Accept okay?
So there is a difference in concentration of the Accept and the Alcavis. So the more dilute solution is what should be used on the skin, anything that comes in contact with the skin, and the more concentrated formulation to be used on the tubing transfer set and non part of the dialysis equipment that comes in contact with the skin. So you tell
yeah, so David, the Accept is for the exit site itself, and the Alcavis is specifically for the connections according to DaVita policy and procedure.
Thank you. So it is the lower concentration, and the Alcavis is the higher concentration for the tubing.
Correct.
Okay, and if there are no more questions, I'll read another one from the chat box here. This wants to know, why are we not using betadine anymore?
So there are some potential complications with betadine. Again, it's catheter specific. Some betadine solutions can lead to some cracking in the tubing. So we've migrated away from betadine skin preparation to accept dose containing solution to prevent infection.
Sarah, do you have any other live questions?
No questions.
Okay, I'll read another from the chat section here. Dr. Roer, how is your center's success with pre-sternal PD catheter placement?
Great question. Anecdotally, we've had very little experience with pre-sternal catheters. I think they do play an important role in the right patient. I do think that there is a steep learning curve for the surgeon to insert a pre-sternal catheter, since it is a bit different than placing a peritoneal dialysis catheter in the abdomen. We have used high abdominal insertion sites for some obese patients with very, very good success. But personally, I don't have experience with pre-sternal. The literature would suggest very, very good outcomes, and it clearly is an acceptable option. My own caution is to a referral to a surgeon that has some experience in placing the catheter.
Thank you. Do you have a live question online?
There are no questions.
Okay, I'll read another from the chat section here. Dr. Roer, when should a fistula be placed? I'm assuming that this individual means if they have a patient that's already on PD, that they'll be transitioning to HD. When should we place that fistula?
Of course, this is somewhat controversial and very a style of the care team. There is a strategy in placing a fistula in patients even at the time of initiation of peritoneal dialysis with the anticipated need for using it at some time in the future, or beginning with peritoneal dialysis and as time goes on, place an AV fistula if one can anticipate a failing peritoneal membrane. With the latter strategy is there can be unforeseen complications which might require in-center CVC accessed therapy, but many of those episodes can be avoided. For instance, many patients will go into in-center backup for hernia repair or a pleural leak, and many of these complications can be managed with low-dose cycling therapy or in-center IPD to avoid the need for a central venous catheter and in-center backup. So it takes a lot of planning and knowing what the options are to avoid placing a CVC. But I think timing of an AV fistula is important, somewhat specific to the patient and to the course
peritoneal dialysis and the anticipation of complications.
And I'm going to read another question from our chat section here. Patient with increasing dementia, and I am concerned she may crash in HD. Discussed with her family and the nephrologist, but a timeline would be helpful. A timeline that you should be looking at, Dr. Roer?
So the question, a patient on PD or on home therapy who's developing progressive dementia, and the timing of transition to another therapy?
I think that is the question.
So I think the most important aspect of making the decision is to be sure the patient is being fully dialyzed at home. Having a support team at home or assisted home dialysis, either on home hemo or peritoneal dialysis, obviously can keep patients home for a longer period of time. Assisted PD, assisted HD, I think, is an important strategy to keep patients home. It does create increased burden for technique at home, but in the right circumstances, with the right support to help with assisted PD or HHD, can lead to remaining home for a longer period of time.
Thank you. And do we have any live questions?
There are no questions.
Okay. From the chat box here. Dr. Roer, in your HHD program, do you allow patients to go home on HHD using the CVC as their access, even with no plans to get a permanent internal access placement?
So, as with all our patients, we want to have a fistula with a graft as the second option. Those CVCs are never our first choice. The patients are always counseled extensively to avoid going home with a CC. In our center, there are no patients with a CVC as their only access. We do have one patient who has exhausted vascular sites and is dialyzed very successfully through a CVC without an infection so far in 2 years. This patient, however, has had CVC infectious complications, and we'll be transitioning her home in a short period of time to try to avoid the potential risk of CVC complications in the future.
Thank you. Our question from our chat section here. Based on the study presented, diuretics help with urine output and thus increasing URR. What happens if the patient is not making any more urine? They still need to be on diuretics.
Yes, I think the greatest importance of diuretics is to try to maintain urine volume and residual renal function. As urine volumes go down, that's concurrent with a fall in residual renal function. So I think once urine volumes fall below 2 cc's per day, that there may be diminished returns from the continuation of diuretic therapy.
Thank you. Do we have any more questions?
No questions.
Another from our chat section here. Is the exit site care with accept ended over liquid antibacterial soap and water for well-sealed exit site?
So I think the simple answer to that is yes. It appears to be superior to preventing exit site infection, tunnel infections, and peritonitis. So I think it's wise to use Accept as the solution choice for skin care around the catheter site. As we had discussed a bit earlier, soap and water is a reasonable alternative, but my first choice would be Accept or Gravist for the tubing.
And any opinions on this one as well?
So right now the policy and procedure for well-healed for DaVita is soap and water. We do use the Alcavis when we connect or disconnect.
Thank you. Sarah, I'll put out my last poll for in-person questions and other poll for any questions to be typed into the chat box. Questions out there, Sarah?
There are no questions.
Okay. Well, and if there are no more questions, we'll go ahead and stop here. I do want to take a moment to thank everyone again for participating and to especially thank our speaker, Dr. David Roer, for taking time out of his busy schedule to talk with us and for also being so flexible with us as we rescheduled the PD webinar from last week to this week. Everyone, thank you again for attending. As a reminder for those nurses in attendance, you are eligible to receive 1 continuing education credit for today's presentation, as well as 1 credit for each of the 6 previous webinars in the current series. I will send an email out to all of the nurses in participation today that has the code on it. This is the learning code for this month's webinar. Please be joining us for our next and final webinar in this series. That's going to take place on Friday, May 4th. The topic is successfully starting incident crashers on PD. And our host for the May webinar is Mark Shapiro out of California. Again, for attending, everyone, and have a good day.
Thank you.
And this concludes today's conference call. You may now disconnect.